most of my focus is spent in the outpatient world. 95% cancer patients. I see them for early on in the course for pain management, symptom management, and throughout the course of their disease, progressing towards the end where we're talking about hospice and transitioning toward kind of a comfort-focused care. About 50% of all palliative care is focused in the cancer world, depending on where you are, because it's a natural fit. It kind of grew out of cancer, as did the hospice. The nice thing about the expansion of palliative care is that it now exists in the worlds of heart failure, COPD, Alzheimer's, other sort of diseases of aging that are as difficult to, I think, live with and prepare for sort of how to best take care of yourself or your family member as the disease progresses. Hospice. Without a doubt, it's the one, and it's not just my patients and families, it's other healthcare providers, it's other physicians, it's other nurses. And I wish that's the one thing that I wish we could sort of eradicate, is the idea that palliative care is synonymous with hospice, because it really isn't. And I think it does a disservice to being able to help our patients and families if we think about it only as something that is the last few months or weeks of life. Supportive care. I tell my cancer patients and their families, your oncologist is your cancer doctor. Cancer has innumerable side effects: physical, emotional, spiritual, financial. I help deal with all of those side effects. So it is equally as efficacious to get a palliative care team involved 3 weeks after your diagnosis of colon cancer. And in some ways, we have good evidence that shows help patients and families live a better life. It's not just talking about dying. The mortality rate is still 100%. So I think, especially in this culture, in ways, we've done a good job of looking at how to extend our lives and make ourselves feel immortal. But the honest to God truth is that all of us have to face this at some point in our lives. Certainly sometimes tragically sooner than we want, but the shift in focus, it shouldn't be about how you die, because that's relatively a straightforward process. It needs to be about how you live up until you die. And if we can get everybody to look at it that way, I think there is a pot of gold, right? I can tell you, listen, I can't make your time longer, but I can certainly work with you to make it better. And I don't know many people that don't find that a reward. I think a lot of it is listening to patients and families. Tell me about yourself. Tell me what is important to you. Tell me what a good day looks like for you. And then I use whatever tools I have to help achieve that. Sometimes it's medicine, sometimes it's yoga, sometimes it's help thinking through financial planning with our social work colleagues, getting people in with the right sort of paramedical support if that's what they need. The growing acceptance that this is not something that means giving up. I think it's a slow evolution, but just in the past decade or so, thanks to some of the trailblazers out there in the field of palliative care, Diane Meyer, Susan Block, Atul Gawande, people like that, the medical community, and more importantly, the public at large, is just starting to recognize this is something that can help me live. We're a bit stuck in that we have a huge workforce shortage. There are never going to be enough palliative care clinicians to take care of all of the patients who need it and would benefit from it. I think the future of palliative care truly is in helping educate everyone, providers, patients, families, everyone in the general public, about how to have more comfort in talking about these decisions, in planning for the future. And then certainly I think as the field advances, there is a great role for specialized palliative care for people that have refractory symptoms, for people that have very difficult psychosocial interactions, things like that. I think in that way, we have sort of a two-pronged responsibility to our patients and to our fellow clinicians. Is one, to educate everybody to be able to do this a little bit, and then just to be there as boots on the ground, taking care of complicated patients. I'd make the argument that to be a good doctor, first you just have to be a good person. I tell all of my students all the time, stop thinking with your doctor brains. Think with your normal person brains. There is so much more to this than getting the right diagnosis or changing the dose of the medicine. That's certainly important, but I think the more that we can focus on that this is just a human-to-human interaction, that's what makes it different. And some of learning communication skills, which is so integral to palliative care, is what makes you be able to do that. It makes you be able to be present in the moment. It makes you be able to take that deep breath and say, I don't have 3 hours to talk about this with you, but I can do it really well, maybe in 10 minutes. I think there is a lot to be said for the specialized training that palliative care clinicians provide. Now, they can exist anywhere, as can specialized oncologists. It's certainly not as geographically limited, but I think this is one of the ways where using technology in medicine is going to help us expand care to everybody, not just the people that are right near a tertiary care center, like we have the luxury of being in Philadelphia. But I see, the benefits of having experts at places like this being able to reach out to patients and families that are in more rural locations via telehealth, having home programs that communicate with me at a tertiary care center. I think that's the way to use technology to help expand access to services like this. The same as we do for oncology or specialized heart failure or anything like that.